Welcome back to the Nervous Breakdown. Have you ever heard that you should not let someone go to sleep after a head injury?
Some people think that's good medical advice, but that may be just from movies. Is that good advice?
Well, let's talk about it. Today we're going to talk about head injuries and how they're not just about being knocked out. You can also have a serious brain injury and never lose consciousness. So we'll cover several topics: concussions and brain bleeds and diffuse injuries. We're going to talk about several myths, several red flags or when you should worry, and why all this matters. So let's get right into it. Estrada, can you tell us more about concussions and what that actually means? You hear about that a lot in movies and you see that in everyday life with sports. What does that mean and what are the implications of that?
That's a good question. So, concussion doesn't necessarily mean you have to lose consciousness. Concussion is basically a disruption of the brain processes that occurs after there's been an impact to the brain. Classically, it's a process in which you're moving, your head is moving, and all of a sudden it gets struck, and then it stops moving, and so then the brain shifts around in the head, and that can cause disruption. Now, it's a continuum. There's a wide range. So at the most mild form, there may not be loss of consciousness. Then as you go further along in severity, there may be a brief loss of consciousness and then the person awakens. Or it might be so much disruption that the person ends up being comatose. And that's called diffuse axonal injury. So all of that is a spectrum going from a mild concussion to comatose with diffuse axonal injury.
So in medicine, we like to use these big words, and concussion is not that large, but just to make it clear, it could be any type of brain injury from you bumped your head relatively hard to you've been rendered unconscious from a big hit on a football field. Is that accurate?
Yes. Yeah, so typically you might see it watching a football game. Somebody gets struck in the head and they might have a concussion, and people are well familiar with going through the concussion protocol. First of all, they have to establish whether the person did have a concussion, whether they lost consciousness or not, and then evaluate and treat based on that diagnosis.
Okay. Now, some people that have a concussion or hit their head, they're on medication, say blood thinners for atrial fibrillation or something like that. Some of these people can actually have bleeding into their brain after having a concussion. How often would you say that occurs, or what would be the features that make that more concerning for you as a neurosurgeon?
So it's not so much the concussion per se, because concussion tends to be relatively mild. So the risk might be a little bit higher than somebody who's not on a medicine that slows down the blood clotting. But it's a matter of how much impact. And if there's enough impact, whether you're on a blood thinner medication or not, there can be disruption of the tissues in the head that can cause bleeding. Now, people have heard about subdural and epidural. So there are different layers where the bleeding may occur. Epi means above. So dura is the covering over the brain itself. So if there's bleeding in that space above the dura, above that covering, is called an epidural hematoma. Hematoma means blood clot. And if it's below that dural layer, it's called a subdural hematoma. And if there's disruption of within the brain itself, then that can be called a contusion or an intraparenchymal within the substance, intraparenchymal hematoma. Hematoma again means blood clot or bleeding.
But the treatment for those would probably be different if you are intraparenchymal, so deep inside the brain, versus an epidural, which is all on top, on the outside of the brain for the most part. The treatment would be somewhat different in those cases, correct?
So it's a matter of severity. And if you have a small epidural hematoma that's not expanding, then nothing would need to be done if it's not associated with any major brain dysfunction. Now, one of the things about epidural hematoma is that it's something that can occur, that can evolve very rapidly. And classically, it's because there's been a fracture in the skull that cuts through an artery that's in the dura, at the surface of the dura. And because it's arterial bleeding, that can expand very quickly and somebody can deteriorate rapidly. So in those situations, somebody needs to be seen very quickly to get the blood clot removed and to control the bleeding. So that's the epidural hematoma, and classically it's described as people who talked and then deteriorated. That is, they got a hit to the head. They initially were doing fine, and they may not have lost consciousness with that initial hit, but in the time frame that that blood clot is accumulating in the epidural space, that will lead to deterioration. And then once there's deterioration, that can happen very rapidly, and then that's when you need emergency neurosurgery drainage. Now, in a subdural, that's usually not arterial. Is usually, and the blood from the artery tends to pump faster and produce more volume. The subdural is usually from the veins, and so there's usually less of it. And it depends on how much force is applied to the brain, whether with that subdural blood, there's also damage to the brain itself. And if there's a lot of blood in that subdural space, that can also require surgery.
And so just to make it really simple for some other people that listen to some of our other episodes, a disc herniation can press on a nerve, and if that nerve is compressed long enough, the function can stop. So same thing with like these blood accumulating in the brain. If it's pressing on the brain enough, it's putting a lot of pressure suddenly, and that function can be lost. And so that's why treatment for it is very urgent if it's something that is causing, the functional deficits that you talked about.
Yeah, so it's a matter of pressure, but the significant issue about pressure is that it impedes the blood flowing into the brain, because inside the skull is like a fixed box. So if you have blood accumulating into that space, then there's not much more room. And if you have a limited space but increasing volume of something in there like blood, then the pressure in the head will go up, and it will get to the point that it exceeds the blood pressure that's normally being used to get blood flow into the brain. So if that pressure in the head is higher than the blood from your heart going into the brain, then your brain isn't going to get enough blood flow, and you'll lose brain function and become comatose, and it could lead to death if it's not addressed.
Just like a heart attack, the heart's not getting blood. Same thing for the brain. The brain's not getting blood, and there's two ways that can happen. One is that there's pressure in there, and the other thing is that if something happens to block it, then similarly your brain is not getting the oxygen that it needs to function, and it just eventually shuts down, which is a problem. Let's talk about some of the common myths. So I'll say something that is commonly repeated, and you give us your take. How about that? So if you didn't black out, you didn't have a real injury. How about that one?
No, that's not true. As I said earlier about concussion, you don't have to black out in order to have an injury to the brain. And you may not even see it on a CT scan.
Which is the next one. So I've got a normal CT scan. That means I'm fine. I should be able to go home.
It depends. Usually if somebody has a normal CT scan and they have a good brain function exam, they will be released home. But if there's been a concussion, a known head injury, they're going to be released with instructions on what to look out for. Because if there are certain things that occur, then you might need to be brought back for evaluation, because it could mean that there's something deteriorating.
So they underscore, it's very important to have the evaluation and to go and see someone to make these decisions, to help you make these decisions. So next one, we'll do one more. I hit my head and my family told me I can't go to sleep.
Yeah, that's another myth. Going to sleep is not necessarily an issue. In fact, after a concussion, it's not unusual for people to be a little bit sleepy. But I think this myth occurred during an earlier phase when we didn't have the technology we had now. We can do CT scans and see what's happening in the brain. And when people didn't have those tools, they wanted to be able to evaluate how people were doing, and so they may have kept people awake. But keeping somebody awake isn't the issue. The issue is there progressive loss of functioning? Is somebody deteriorating? So usually we would recommend not keeping somebody up all night, but maybe checking them every 2 to 3 hours to make sure they're doing fine. They're not getting confused. They're not getting weakness. They're not to the point where you can't arouse them. Those are those are what's called red flags. Those are things that would be concerning that would prompt further evaluation.
Sure. Let's talk more about those. So things that would be concerning. We should start with the basis that there's certain parts of the brain that are responsible for certain functions and activities, whether it's speech or movement, etc. So naturally, when you have an injury that's affecting the brain, you can sometimes figure out what part it might be based on what symptoms it present with. But a universal one may be a headache. Sometimes you have headaches, and they say it's the worst headache of their lives, right? And so those are things that make people know that they should go in. You should go get that evaluated if there's a change. I normally have headaches, but this is very, very different. You might want to get that evaluated. Other things that happen with the pressure change is people often become nauseous and have a lot of vomiting. So they have a head injury and they're vomiting, headaches, you definitely want to bring them in. Confusion or personality changes, and this is something that can even happen down the road. We talked about subdural hematomas, so the blood accumulating usually from the veins being disrupted. So that's going to be a slower onset. And they'll say they've been acting a little bit different over the last week or two. It doesn't have to be within 24 hours. It can be a delayed thing. And then, of course, with the other areas of control, slurred speech, the weakness, checking the pupils. And you see that a lot in the movies. They shine the light in the eyes, right? And then certainly if you see someone have a seizure, then that's going to be a clear sign that they need to be evaluated immediately, right?
Yes, those are all good.
Yeah. And we talked about football earlier as an example for head injuries, concussions, and things of that nature. Repeated injuries can probably lead to cumulative effects. So, in closing, when it comes to head injuries, change over time matters more than what happened, the initial hit, and we need to be evaluated immediately if you have concerning symptoms that we just mentioned as the red flags or things that should make you concerned. We're almost out of time. Any closing thoughts?
I think the important thing is to get evaluated in this era. If there's anything that's very concerning, it would require a CT scan, or it could require more extensive evaluation depending on what's found when you're examined. After the injury, there can be personality changes, like after a concussion. So it may not be unusual to have memory issues, sleep disturbance, and personality changes. That may be, not necessarily is always the case, but that can be a sign of post-concussion. It's called a post-concussive syndrome.
Right. And there you have it. If you hit your head, see someone. Nervous Breakdown, like and subscribe. Put any questions in the comments, and we will look forward to seeing you next time. Thank you. I'm Dr. Gay.
I'm Dr. Estrada Bernard.